back to the discussion on PSMA PET scan. Are you guys aware of there are different tracers utilizing PSMA PET scan? There are gallium-68 based and fluoride 18 based PET tracer. Any idea about the differences? I know in the hospital setting we are limited by the hospital decision, institution decision, and nuclear medicine department decision. But any thought about differences among different tracers?
No, I'm not aware of differences. I just usually order what the hospital has available. Like I work in a community setting in smaller hospitals, so they probably just have one tracer and they tell us, okay, order it with this. That's what we have available.
And it seems that obviously there are at least three FDA-approved radio tracer utilizing PSMA PET scan, gallium-68 based versus fluoride 18 based radio tracer agent, and obviously, this is not our specialty, but it seems that the fluoride 18-based tracer seems to have better spatial resolution and more stable, longer half-life compared to gallium-68. Price-wise, fluoride 18-based agent seems to be cheaper. In our system, we use Polarify, and which is fluoride 18-based radio tracer. We also mentioned when patient diagnosed with prostate cancer, say unfavorable intermediate risk situation, and then you order PSMA PET scan, and there's actual iliac lymph nodes that showed up on the PET scan. How would that change your initial plan in terms of managing this locally advanced prostate cancer? Dr. Raj?
Obviously, the first treatment is androgen deprivation therapy. And we know that adding the androgen receptor targeting agents as well, in addition to the, seems to be better than ADT alone. But if you have isolated lesions, we alluded that maybe SBRT to certain areas for oligometastatic diseases can be considered. I don't know exactly whether it...
Treat it as a localized prostate cancer, right, with a regional lymph node. The radiation is still going to focus on the prostate. And if we decide to pursue radiation, we're going to radiate the primary prostate. And the radiation plan may be different from the original plan, and for a unfavorable intermediate to now a high-risk disease now, with an N1 disease now. So it changed the perspective of the management strategy. The radiation plan will be different. We're going to not only radiate the primary prostate and either SBRT to the N1 disease or radiate to the pelvic side wall. And from a systemic therapy standpoint, and for unfavorable intermediate risk, the ADT duration typically will be 6 months. But now with the N1 disease, that will change the management, right? And for this patient with a high-risk situation with N1 metastasis, and I would consider long-term ADT and plus ARPI, in this case, abiraterone, right? Any thought?
Yeah, I agree with that. Sometimes there's a question of whether we believe that the node seen on the PSMA scan is real. If there's a CT correlate, even if sub-centimeter, and it's very much in the iliac chains and in the typical regional distribution, then I would be inclined to believe it. If it's Gleason 3+4 disease with low percentage of pattern 4, and it's just pinpoint on PET and there's no CT correlate, then I might give the patient the benefit of the doubt and assume N0. But as a general principle, if there's regional lymphadenopathy, then I would typically advise that they have, long-term ADT in addition to radiation to the prostate nodes, and then we could discuss the benefit of adding abiraterone to improve metastasis-free survival.
So you bring up a very good point. It's a very sensitive test and high sensitivity compared to conventional imaging studies. But there are false positive scenario. And what is the most common false positive findings on the PSMA PET scan?
We have a variety of benign causes, also inflammatory conditions, which can show up as a high uptake on the PSMA scan, like sarcoidosis and a lot of adenomas and thyroid nodules. So those things can come up on a PSMA. So you have to be aware of that and correlate the clinical situation.
Did you ever do like a bone scan in addition to the PET scan, just to confirm, or no?
Well, my biggest frustration is we talk about this on tumor board. If not every time, then almost every time we see a rib lesion, which we're all concerned about, and it's kind of pinpoint, and there's no CT correlate whatsoever, and the disease is not particularly aggressive appearing, and we wonder if this is real or not, especially if it's oligometastatic, meaning it's only one spot, and those are the hardest cases. And sometimes a bone scan can be helpful. Usually, if it's positive on a bone scan, you'd expect to see some sclerotic features on the CT. But I think a bone scan certainly can be useful, and it's especially useful for seeing the skull and the extremities. So
Yeah, go ahead.
Are you ever concerned, though, about if you have a small node lighting up, how close it was to biopsy? Is it a reactive node?
exactly. Oh yeah. I mean, especially if it's small. I mean, a 3 millimeter node is not a pathologically enlarged node, and this is a disease for which we're seeing these tiny things, and they would never ever get characterized as pathologic on a standard scan. So, I mean, again, if it's a patient with really high grade disease and they have a bunch of 5 millimeter PSMA avid lymph nodes, they're probably real. But yeah, very much so. We're catching a lot of false positives, and there are definitely patients who we're over-treating. Because
There's one publication from nuclear medicine field looking into rib findings. I would say probably majority of those rib findings are false positive.
Because I think it's a big deal if you're going to then be changing their course of ADT.
exactly.
Potentially.
The whole management strategy, right? Metastatic disease versus a localized disease, right?
Or alternatively, that they have oligometastatic disease for which you would do radiation to the prostate. Or are we going to say that because they have 3 rib lesions plus another spot that we're going to call them high volume? And so in general, I give the patient the benefit of the doubt on the rib lesion if there's no CT correlate.
So this is a perfect segue to a topic about the difference. What do you think of the difference between oligometastasis versus prostate cancer, low volume metastatic prostate cancer?
I think that's hard to answer. I mean, I think oligometastatic for most other general malignancies beyond prostate, if I'm correct, it's 3 or less lesions. So I think that typically we consider those patients oligometastatic, although oligo should be 1, but it is outside of 1. And I believe with high volume disease, it was 5 or more sites, but I could be.
Historically, in the Stampede definition, it was on the chart. I'm sorry, in the charted definition was 4, but one of them had to be outside the spine and pelvis. But that's
Between high volume versus low volume.
exactly.
So we're talking about low volume.
Exactly.
Based on the North American definition or MD Anderson definition is 4 or more bone metastasis with 1 disease, 1 lesion outside the axial bones. So that's North American definition. The French has a little bit different. The latitude and the piece 1 use 3 or more metastases. So that's the only difference. In fact, so that's the difference between high volume versus low volume. And there's another concept in daily practice, oligometastasis. That's oligometastasis equivalent equal to low volume metastatic prostate cancer.
So I think where that's important, again, if you talk to the radiation colleagues, that is a lot of their cutoff for radiating oligometastatic sites. So they typically, if you have more than the 3 lesions, they don't really justify radiating. But if we're having these patients who have these sites outside the prostate, I guess the question is, do you radiate the prostate plus 1 or 2 additional sites?